Postpartum hemorrhage is a Joint Commission requirement to review at minimum every 2 years or annually if there's new information to share with the staff. There is some new information that we are sharing, but we also thought that a review of what we've been doing, how we've been doing in reducing our postpartum hemorrhage over the last year or so. As a reminder, we just want to highlight the problem and importance of postpartum hemorrhage. Postpartum hemorrhage is a leading cause of death in the United States, and we know that timely recognition and treatment is critical for preventing maternal morbidity and mortality. We know that postpartum hemorrhage is defined as a blood loss of 1 liter or more, or blood loss that's less than a liter, but it's accompanied with signs and symptoms of hypovolemia. In the last several years, hemorrhage has been in the top 4 reasons for maternal morbidity and mortality in the United States. And you can see where it's ranking currently in terms of maternal morbidity and mortality. And here at the University of Michigan, our goal is to have a hemorrhage rate of 10% or less. That's combined C-sections and vaginal deliveries. And you can see over the past several years the work that we've done in reducing our postpartum hemorrhage rate from 17.6 in 2021 to 12.1% in 2024. That 5.5% reduction in hemorrhage since 2021 is about 290 patients who didn't have a hemorrhage. So that is a significant change for us in terms of management of hemorrhage. And if you think about those patients who didn't have a hemorrhage, they didn't require blood transfusion, escalation of care, transfer to the SICU. So these are patients who went home feeling well, when in past years we would have had those patients going home discharged, not feeling well, or having had escalated care because of a hemorrhage. So what did we do to reduce postpartum hemorrhage here at von Voigtlander? We started doing more timely recognition of quantitative blood loss with the Don't Wait to Weigh campaign and implementing labor techs. We also instituted more timely treatment with uterotonics. We changed our rate for Pitocin, the AMTSL rate for vaginal deliveries and C-sections, and unified that rate across both types of deliveries. We also added the JADA device. And then we also recommend attending simulations, so postpartum hemorrhage simulations. We have done on-unit simulations with postpartum and with the labor unit. We've done simulations in the adult ED. We also have simulations coming up that we'll be conducting in Children's Emergency Service and the SICU. Basically, anywhere where our patients can be housed is where we're going to be trying to do simulations for hemorrhage as well as hypertension. And then we also have the ACOG Eco course, which is available to labor nurses currently, where one of the simulations that we participate in is a hemorrhage simulation. So what else can we do to meet our goal? We need to continue to perform our risk assessments, obtain a QBL within the first 15 minutes following a delivery, and then every 15 minutes after until repair is complete. If you are a postpartum nurse, if you have a patient who has a gush of 250 cc's or more, you would want to start weighing those pads and documenting what your QBL would be. If you are on the labor side and you have no labor tech available to help with your quantitative blood loss, request an additional nurse to do QBL if staffing allows for that. Early treatment is key, so we want to give uterotonics in preferred order. We'll talk about that in a minute. And the goal is to begin uterotonic administration when your QBL is around 500 cc's. Make sure you attend simulations, attend the ECO course if you're in labor and delivery, and Missy wants labor and delivery nurses to attend that every 3 years. It's paid for by the unit. You get paid business time for it. The course itself is about $120, which again is paid for by the unit, and you get CEs for it. And then make sure you activate early warning team to bring added team members to the bedside. And when you have vital signs that are abnormal, even in the setting of a normal quantitative blood loss. So you have blood loss of 500, but your blood pressure readings are 90/50. You must have further assessment to figure out what's the cause of the blood pressures being low. And if her vital signs are telling you she's hypovolemic, she probably is. Making sure that you give uterotonics in order. We do our AMTSL rate Pitocin first, and then if you have bleeding or hemorrhage like bleeding, you want to give Methergin and or Hemobate first, depending on your contraindications. If you've given one and it's not effective, you can give the other one as long as there's no contraindications. With that being said, sometimes patients might have remote contraindications like childhood asthma, but have not had an asthma attack in many years or during the pregnancy, is not on steroids. They can give the patient Hemobate. Likewise, if the patient had hypertension, but during the delivery, her blood pressures are normal, they may give her Methergin. The last option would be misoprostol. We would give 800 micrograms rectally. It's the last choice because of the efficacy. And then we have listed here TXA, which is an antifibrinolytic, helps delay the breakdown of clots, but it is not a uterotonic. So what is new? We have we know the JADA and the Bakri. What's new about them is that if you are a labor nurse, you're going to be assessing and documenting the volume of bleeding every 15 minutes times 1 hour, and then every 30 minutes times an hour. For the JADA, after the second hour, you're going to document bleeding hourly until the JADA is removed. And for the Bakri, you're going to document after the second hour, document bleeding Q4 until the device is removed. And then you're going to assess and document fundal height and firmness. You're not expressing or massaging the uterus, but you're assessing the fundal height and firmness. And you're doing that every 15 minutes for an hour, then every 30 minutes for an hour. For the JADA, after the second hour, document height and firmness hourly until removed. And the Bakri, after the second hour, document fundal height and firmness Q4 until removed. As a reminder, we never connect the JADA to Neptune suction. It's always wall suction. With the JADA, vag packs are not needed unless there's a clinical indication. So if there's a vaginal wall laceration requiring some vag packs, then we would want to place those. Have a conversation with the provider to make sure that you know what their intention is for the vag packing. With the Bakri, we need to have a deflation plan, and you must have an order written for that deflation plan for you to deflate the Bakri. And then we want to make sure that we document the Bakri and the JADA in the avatar under intentionally retained objects, and then remove from the avatar when they're removed. And there will be a slide coming up that will show you where to document that. Also, we have the debriefs. You want to document a debrief if you have a postpartum hemorrhage on the form. They're usually in the patient's admission packet, and place those in the supervisor's office at the end of the shift. If patient has a delayed hemorrhage on postpartum, those documentation debrief forms typically aren't traveled with the patient because they're turned in at the end currently, whether you've had a hemorrhage or not. But there are some forms at the desk. So if you have a hemorrhage in a postpartum room, please ask for a debrief form and fill that out and turn that in. With an MTP, which is typically when we have to give an MTP, we're back in the OR and anesthesia is managing the administration of the MTP. But when the units are done, when each unit is given, we have to make sure that we document the volume of blood in the blood administration flow sheet. You also want to make sure you stop that transfusion in the MAR so that it stops the flow rate, and then document that volume. So that is a little different for us. Anesthesia will document the blood unit, but we have to document the volume infused. And then also the early warning team, there's a little bit of a new activation algorithm, and we'll review that in a slide coming up. And again, postpartum, notify your provider if a large gush of blood of 250 or more. You might want to, if you have a gush of blood, you don't know if it's 250 unless you weigh it. If it is 250, you're going to document that and activate early warning team.